We're going to be talking about evidence-based treatment algorithms. I think I mentioned this earlier in the course that there's been a move from consensus guidelines where you just get the experts together and get their opinion about which medications are most effective and treatment strategies. These evidence-based medical studies look at large-scale empirical studies, and they have, and some of the studies are using thousands of subjects, and they then treat them with medications and see which drugs work best. And in particular, not only that, but the studies try to focus in on determining if the first strategy doesn't work, then there are many options that you have, but it would really be good to know what is the highest yield second step strategy. Rather than taking a shot in the dark, if you can go to some data that says this actually works better than this, then that certainly would make a lot of sense. Before we launch into this, I want to talk about something that is absolutely critical in terms of success in treating depression. And this is not about drug treatment per se, but it is essential, and that is the clinician really knowing about the nature of this illness of depression. As you can see on this slide, the dropout rates, the premature discontinuation of medications is extraordinarily high in people that are depressed, and this is probably owing to at least a couple of things. One is pessimism and hopelessness. And there are many people who ultimately could respond very well to an antidepressant, but they leave the psychiatrist's office and they have a prescription in hand and they say, well, the hell with it, and they throw it in the trash. Some studies show that up to 30% of people don't even fill their first prescription. And this is depression. This is the landscape of depression. So they don't even have a chance to see if the treatment's going to work. The other thing is that they take the drug for a couple of days. They don't get better. Well, it's well known that in all cases, with one exception, which we'll talk about later, which is premenstrual dysphoric disorder, in all cases, antidepressants take, as I'm sure everyone knows, a number of weeks to really work. Even if the patient has been told about needing to wait 2, 3, 4 weeks or so before they can expect symptomatic improvement, it's not uncommon that 2 or 3 days into treatment they don't feel better and they say to hell with it and they stop taking the medication. Another issue that is just absolutely common in depression is exquisite sensitivity to side effects. And side effects are unpleasant, can be unpleasant for anybody, but this is the group that has the highest risk of having side effects, even minor side effects, be a cause for just stopping the medication. One thing is that if they have a bad reaction to a medication, and if they start feeling worse, then they not only stop the treatment, but they may also completely say, forget it, I'm never going to try this approach again. And they may have a lifetime disorder here, or one that's going to recur throughout their lifetime, and now they've opted out of any kind of treatment, so that can be a double tragedy. But the other thing is that, getting back to this exquisite sensitivity, I remember years ago when I was first starting out as a psychologist, I worked in an HMO, and people would come in, and they'd be experiencing this horribly severe depression. They couldn't get out of bed. They were thinking about killing themselves. Their wife was about ready to leave them. Very severe depression. And so we start them in psychotherapy and start on medications, and typically see them a week later for the first follow-up visit. And people will be coming in, and I oftentimes ask, okay, how are things going with the medication? And let's say this is a man. He says, well, I'm not taking it. And I say, oh, okay, well, how come? And he said, well, I took the first dose and I got a dry mouth, and I just flushed down the toilet. Now, here's this guy whose whole life is going down the toilet. He's in very serious shape. He may be quite suicidal, and being a young, naive psychologist, I felt like saying, are you out of your mind? You get a puny, dry mouth and you stop treatment that might save your life? What is going on here? But I wouldn't say that. I try to be supportive and say things to him like, I understand you have a dry mouth, or I hear you have a dry mouth, something like that. My impatience with that, my just, being bewildered by that, was because I didn't understand about depression. And these folks it's like their cup is full and you add one more drop of water and it spills over. The degree of despair, pessimism, hopelessness is enormous. They run into the slightest little bump in the road in terms of side effects, and they're going to oftentimes stop taking the medication. So that's a critical issue, okay? As you can see from the slide, there's been some studies, especially done in primary care, that premature discontinuation is much more likely to occur in patients. Now, this probably, intuitively makes sense, but patients who, from the get-go, were skeptical about antidepressants. It's absolutely critical to really have this conversation with depressed patients about taking medication, and to, if you believe medication is indicated, to tell them, I believe you have major depression, talk about various treatment options, including psychotherapy and oftentimes exercise and other non-medical approaches. But in talking about antidepressants, to say, this is what I would recommend, but I really want to talk to you about this. Let's spend some time, because I want to know, what have you heard about antidepressants? And get them to open up about this. Because here you're going to find out some people have a positive expectation. They may say, gosh, my sister took this drug and boy, she really got a lot better. Okay, well that's good. And that's probably going to foster a better, at least initial placebo response, if nothing else. But a lot of people are going to say, well, actually the truth is I read some article that these drugs, make it commit suicide. I'm kind of scared about this. Or, even though these drugs are not habit-forming, people will express concerns about getting addicted. So, critical. And the problem in primary care, as we've talked about before, is there just isn't time to do this. So, it's really important to do this. And I've had some patients who I knew could benefit from antidepressants, but it was so clear they wouldn't take them that we needed to do some psychotherapy for a while until we got to a place where they started trusting me and we had more time to talk about their fears. And then, maybe after 3 or 4 weeks, or sometimes even longer than that, then it was more realistic to talk about the use of antidepressants and more likely to be successful. Patient preferences for specific medications. Let me give you an example. Let's go back to what I mentioned a minute ago. Someone says, hey, my sister was depressed and she took Zoloft and it really worked for her. Well, if all other things already are pointing in the direction of using an SSRI, there are several choices, obviously, Prozac or Celexa or what have you. But this positive set, cognitive set surrounding Zoloft, then it probably makes sense to say, well, actually, you know what, that's in a class of drugs that I think makes a lot of sense. So why don't we go with that? And then finally, and this is a really big deal, and we're going to spend a lot of time talking about this, but it's inaccurate diagnosis. And here, just very briefly, let me highlight a couple of things. One is, not infrequently, people are coming in and have a major depressive episode, but it turns out, on a more close inspection, they have bipolar disorder. This is more commonly seen with bipolar II because of hypomanias rather than full-blown manias, but these people don't respond to antidepressants, and actually antidepressants can make things worse. Another example might be a person who has an underlying medical condition, like thyroid disease. You can treat with antidepressants, and it's not going to be successful if there's this underlying endocrine problem. Or somebody that's taking a medication, some medications, in particular high blood pressure medications, can cause depression. So the diagnosis is critical. Now, it may sound like I'm stating the obvious, but I got to tell you the truth, and that is, these are the problems. This is where treatment crashes on the rocks of not really understanding depression and being very thorough about evaluating various potential causes for the depression. Next, let's talk about the use of rating scales. And you have these rating scales available to you. We're going to get into the details of this later. We'll take a close look at how to use rating scales, but very clearly, the use of rating scales can significantly improve outcomes in pharmacotherapy. And so I'm going to encourage you to use those. The largest study ever done, looking at the treatment of major depression, found that the use of rating scales was a significant contributor to successful outcomes. First weeks of treatment. Now, because these people are so likely to give up, to bail out of treatment, psychotherapy and or medication treatment, it makes a lot of sense to try to get some symptomatic improvement as soon as possible. Now, that can't be done with antidepressants alone because it takes weeks for them to really start to have actions. But we're going to be taking a look at several approaches that are strongly suggested as being important, especially in the first week or two of treatment. And these are recommended also by the American Psychiatric Association practice guidelines on treating depression. We will look at some medication strategies where adding medications to antidepressants sometimes can yield very quick onset of positive symptomatic improvement. So there are medication strategies that will address this. Next is exercise. I wish I had an hour to talk to you about the research on exercise in depression. Exercise is significantly helpful in treating depression. Not only a quick fix, 15 minutes of vigorous exercise, brisk walking or jogging almost always results in some elevation of mood. Daily exercise over a period of weeks has been shown to be ultimately as effective as antidepressant medications. So getting people to get active immediately after their first session is very important. Now, let me just digress for a moment. And that is, this looks great, the research looks great, and we know as clinicians that this is darn hard to do with people who are depressed. You can stand on your head and talk to them all day about how important exercise is, but the truth is that it's rare that a person who has major depression will actually exercise. I think the only reasonable way to do this is where you pull in the family member and you really have this kind of talk with them about you're going to need to be the coach. This is a husband, wife, partner, could be a parent if you're looking at a child or adolescent, but not only encouraging the person to exercise, and again, you don't have to be an athlete to do this. So even people that are not very fit, 10 to 15 minute brisk walk can make a difference. But not only encouraging them, but also do it with them. That's one of the highest yield things you can do is to have the husband go out with his wife and say, let's take a 15-minute walk. And that begins to be move into an area that is realistic. But if you try to just encourage the depressed person to exercise, it could work. Bright lights, we're going to talk more about high-intensity light therapy later. This is used often to treat seasonal affective disorder. But also, what's been found is it can be a mood elevator, can have antidepressant effects in people who have non-seasonal depressions. And again, the details are going to come later, but this is going outside for at least 10 to 20 minutes a day without sunglasses on. And use sunscreen, don't want to get skin cancer, melanoma, and that sort of thing. But the light reaching the retina, bright light, does have mood elevating properties and should be used even in people who have no clear seasonal depression, but just normal unipolar depression. And then finally, it is to combat social withdrawal. And this Peter Lewinson did the initial research in the 70s. And I think he's kind of an unsung hero. This actually is a type of therapy that has some of the highest success rates in treating major depression. And in his program, what he did is he had research subjects sign up, and then what they did basically is they forced them to stay active. You had to show up for scheduled social and recreational events. Nobody who's depressed wants to do this. When people get depressed, they withdraw. They stop answering the phone. They stop going to church. They don't go out to eat dinner. They start really disconnecting, disengagement from life, and just pushing people to stay engaged. Lewinson showed very significantly would actually treat severe depression, even without psychotherapy and antidepressants. Again, this is something that it's unlikely that the patient will do on their own, but if you can get a relative or close friend involved with them and really push this. All of this is aiming at one thing, and that is to get some symptomatic improvement within days, if not even the first day, or the first few days, because, I mean, obviously it feels better, there's less suffering, but the real key issue here is giving them something that translates into hope. And that will keep them on board and engaged in psychotherapy. I'm going to be talking with you real specifically about some treatment guidelines, some algorithms. So we'll cover that in detail in this course. But also, these are two excellent algorithms that you can get online. You can see the first one is endorsed by the World Health Organization. The second one, one of the benefits of that is it not only has treatment guidelines based on the person's presenting symptoms and so forth, but importantly, it references information about drug-drug interactions. It says on the slide, P450, this is a family of enzymes, liver enzymes, and many of the antidepressants can have an impact on liver enzymes, which can affect the metabolism of other drugs. At times, it can result in significant problems, side effects, toxicity, and so forth. So this is a helpful algorithm to turn to. Well, not everybody's created equal, and we see this clearly illustrated on this slide, not only in terms of how they metabolize medication that we've talked about, but also just their nervous system, and there are multiple underlying neurobiologic causes for depression, and so it's probably no surprise at all that not all antidepressants are the same and they all don't work the same. We're going to talk first about choosing a first-line antidepressant. There's probably 20 different antidepressants on the market, and oftentimes, unfortunately, the choice of a first-line medication may not be influenced by any kind of specific science or any kind of empirical base. It may have to do with how persuasive the pharmaceutical rep was with the primary care doctor. That's really not unusual. Or some primary care doctors were taught in medical school and continue to be to this day. This is taught. Get to know two antidepressants really well and use those and kind of stick with those, because these doctors have to know so many drugs and so many things they've got to keep up with. If they become accustomed to really understanding about the side effect profiles of these two drugs, they can stay kind of on top of that, but that really limits their options. So wouldn't it be nice to know from the get-go, which drug to use? We see here in this cartoon up and left, wouldn't it be nice to score hit with the very first drug? Well, obviously, that would be critically important. Are all of the antidepressants the same? No, they're not. They're clearly not the same. Many of them have similar actions, like reuptake inhibition, which we'll be talking about later, but they do target different neurochemicals and have different side effect profiles. There are a number of chemicals in the brain, neurotransmitters and hormones, that have been implicated in the etiology of depressions, of major depression. They're not limited to these neurotransmitters you see on the slide here, but these are the neurotransmitters that are the target of or focus of currently available antidepressants. And it would be good to become familiar with these abbreviations for norepinephrine, serotonin, and dopamine. There are drugs in the pipeline being developed to target hormones like corticotropin releasing factor, cortisol, possibly glutamate, and so forth, but those are not ready for prime time at this moment. This next slide shows something you'll have in your handout, and that is a quick reference to psychiatric medications. And I want to call your attention to two things just for right now. One is looking at the middle column where it says the usual or typical daily dosage. Now, these are really broad therapeutic dosage ranges. And the reason for this is because what really matters is not how much you take of the drug, it's really how much gets into your bloodstream. And we've talked about this before, that people metabolize drugs in very different ways. Some people are slow metabolizers, some are rapid metabolizers. So there's quite a broad range here of dosing. But the point that I want to make are 2 points. One is this is for adults. Now that's typically considered to be between the ages of 16 and 60. Beyond 60, especially beyond 65, as we talked about before, liver metabolism really slows down, and you have to start with lower doses, and oftentimes don't need as high a dose to have a clinical response. But for most older adolescents and adults under the age of 60 or 65, people pretty much need to be at least within this range. Okay, so that's quite important, and the reason that I'm saying that is because in primary care, for reasons that nobody has really been able to explain adequately, I think, is that many people that are treated with antidepressants receive very inadequate doses. It's not unusual at all to have somebody, I've seen people come in and see me, and I've been taking Prozac for 6 months now, but it's not working, and they're taking 10 milligrams. Well, maybe 1 out of 20 people that take 10 milligrams will get a clinical response, but almost always you have to get at least 20 milligrams, sometimes higher, for the drug to work. So this will give you some very rough guidelines about the therapeutic range, so you can evaluate what doses are going to be adequate. The second thing, beyond the dosage ranges here, are the columns on the right-hand side of your slide. And this is sort of an at-a-glance way to see which of the neurotransmitter systems are targeted by these drugs. You can see that some antidepressants are sometimes called broad spectrum, that is, they target 2 or 3 neurotransmitters, or have dual actions. The first drug on the list, for instance, is imipramine. It's an old tricyclic, and it has an impact on both norepinephrine and serotonin, so it's a dual action drug. Other drugs are selective. Probably the best example is Prozac. It's a selective serotonin reuptake inhibitor, and you can see that the MAO inhibitors that we'll talk about only briefly are really the true broad spectrum drugs. They target the enzyme monoamine oxidase and actually increase the availability in the brain of all 3 of these neurotransmitters: norepinephrine, serotonin, and dopamine. So this is a quick reference. But the point I really want to make is that it's entirely possible that if the choice was made to use a drug that only targets serotonin, and the person was treated with adequate doses for a long enough period of time, and yet they didn't respond, one possible explanation for the lack of response may be that their serotonin system is not dysregulated, that they're, in a sense, you're shooting at the wrong target. And so if you 8 weeks on Prozac at high doses, switching to another SSRI, although on occasion it may be helpful, most of the time probably doesn't make as much sense as switching to a different class of drugs that targets a different neurotransmitter, for instance, norepinephrine. So this is a way, again, at a glance to see which of the neurotransmitters are affected by the various drugs. On the next slide, you'll see what some people call new generation antidepressants. These have been developed. Now, actually, Wellbutrin came out in the early 1980s, and Prozac came out in the late 1980s, 1987. But they've come out since then. But they are to be distinguished from the tricyclic antidepressants and MAO inhibitors that began to show up on the market in the late 1950s. And what really distinguishes these drugs from the tricyclics and the MAO inhibitors is that these drugs have a low degree of toxicity. And this is really important because the older generation antidepressants actually were some of the most toxic drugs in the pharmacy. Here we have people that oftentimes are at high risk for suicide, and yet they're given drugs that you could take a modest overdose of a tricyclic and it would kill you. And so one of the major benefits of these new generation antidepressants is that you can take large amounts of these drugs and you're likely to become very ill, but they're not toxic. And there are some exceptions to this, but by and large these drugs are much more safe. And I think we can look at them falling in these 3 broad classes: the selective serotonin drugs, Again, Prozac is an example, but also Zoloft and Celexa, Lexapro, Paxil, and so forth. The norepinephrine reuptake inhibitors. Now, currently, there's only one of these NRIs on the market, and it's the drug Strattera. Let me digress for just a moment. Strattera is FDA approved for treating ADHD. We'll talk about that much later in the course. But it's actually an antidepressant. And the company that marketed this decided there were too many antidepressants on the market that they probably couldn't make much money if they tried to get FDA approval as an antidepressant. But there was data suggesting, pretty good data, suggesting that Strattera could treat ADHD, and so they got approval there. But getting back to the point, Strattera is a norepinephrine reuptake inhibitor. In other countries, in England, Canada, Western Europe, there are a number of other norepinephrine reuptake inhibitors, and they're likely to be more coming on the market in the United States because there's clearly a place for drugs that selectively target norepinephrine, and we're going to see why that's the case here in a few minutes. And then there you can see a list of dual action drugs, and these are ones that target two neurotransmitter systems. Now, getting back to the question about which drug do you use first when there are so many that are available, and this really should not be, just shot in the dark. I think that's really inappropriate. Some information can be gleaned from neuroscience research. This is not pharmacology, but this is from neuroscience research. So we'll take a look at the slides of neurotransmitters and behavior. The first has to do with the neurotransmitter serotonin. Now, there's been studies that go back to the 1970s that show that there are certain kinds of behaviors, so these would be identifiable symptoms that are associated with an underlying dysregulation of serotonin. And you can see on the slide anxiety, anxiety especially that you see with rumination, people who just dwell on things over and over again, the kind of thing you see like in generalized anxiety disorder, and sometimes in OCD as well. Irritability and aggression and suicidality. Now, this last one deserves some special attention because of these, this is the one that has been supported in the most robust kind of way from the research. The original research was done in Scandinavian countries back in the 1970s. Researcher Marie Asperg had hospitalized depressed patients. Now, first let me say, obviously we're looking at the severe end of the depressive continuum here, but they were in the hospital. And what she did is they were able to get spinal taps on a number of patients, and in spinal fluid you can measure, you have a measure of the amount of neurotransmitters. Now, technically you don't measure neurotransmitter levels, but you look at their metabolites. Shortly after these neurotransmitters get in spinal fluid, they get broken down into their metabolites. But it's a way of getting a relatively direct reading about levels of neurotransmitters. Okay, so what she did, she collected data on these very seriously depressed patients, and then did a follow-up a year later. 1 year later, she found that those people who had evidence of very low levels of norepinephrine in spinal fluid, after a period of a year following their hospitalization, 2% had taken their own life. In stark contrast, those that had low levels of serotonin, it was 22% had killed themselves. Now, again, we've got to keep in mind these are very severely ill people, but that's a striking difference. And there's been a good deal of research since then that has supported this. So something about suicidality being associated with low serotonin levels, I think is well supported. Now, the point is that if there are many symptoms that are shared in common across all depressions: low self-esteem, guilt feelings, feelings of worthlessness, pessimism, and sleep disturbances, and so forth. But it looks like if you have a person who has major depression, but there are these prominent symptoms of extreme irritability and aggression, severe anxiety, and or the person has a high risk of suicide or has made serious suicide attempts, all other things considered, if those symptoms are present, it probably makes sense to target serotonin in the choice of the first choice of antidepressants. Now, I want to be really clear about this. This is not rocket science. It ain't perfect. But because there are not good laboratory tests that can determine which neurotransmitter, in a sense, is off track in the nervous system, these behavioral markers can serve as a guide in choosing first-line antidepressants. Okay, the next slide. Dopamine and norepinephrine are kind of kissing cousins. They are chemically quite similar to one another. They are under an umbrella called catecholamines. And again, here from the neuroscience research is that people that have markers of low norepinephrine or dopamine activity in the nervous system are more likely to show anergic depressions. This is low energy, oftentimes accompanied by severe anhedonia and apathy, amotivational syndrome, if you want to call it that. And so once again, if those are the predominant symptoms, in addition to regular depressive symptoms, then it probably makes sense to go with a drug that targets norepinephrine or dopamine. Antidepressant algorithm. And we're going to start here. This is really combining information from the Texas Medication Algorithm Project, from STAR-D project that we'll talk about later, and some other research. And we're coming up here with 4 subtypes of depression. Okay? On the slide, when people have depression and they either have an agitated or anxious depression, or they have major depression with comorbid anxiety disorder, like panic disorder, OCD, social anxiety or something, that's our first category. And that actually represents, across many studies, a little more than 50% of people with major depression. So lots of people have this kind of comorbidity. We're going to also talk about, in a sense, kind of the opposite, anergic depressions with low energy and apathy, atypical depression, which I'll define later, and then finally premenstrual dysphoric disorder. Okay, now, looking at the algorithm, if people present with major depression and or prominent anxiety symptoms or agitation, the drugs of choice are those that target serotonin, the SSRIs. But there's a problem, and the problem is that SSRIs, but this is true for most of the antidepressants, but here we're talking about SSRIs, have the possibility of causing a side effect that's referred to as activation. This is an acute onset side effect, and it occurs typically within a few hours or at least during the first day of starting treatment. It also can occur when you escalate the dose. So let's say somebody has been on 10 milligrams of Prozac for a week, and they're doing okay, and then the psychiatrist decides to increase the dose to 20, which would move it into the therapeutic range. You may see this side effect occur as you're bumping the dose up. Okay? Activation is anxiety, and that's all that it is. But you can imagine if somebody has been, let's say they've been continuously depressed for 9 months. Most people in the United States, when they get really depressed, don't immediately go get treatment. They try to snap out of it. They do everything they can to cope with it. But at some point, it's clear it isn't working. So they finally seek out a psychotherapist or a physician, and they come in with depression. So they've been, let's say this person's been suffering with significant depression, but also accompanied by just ongoing anxiety and agitation for months. So they go home and they take an SSRI, and 5 hours later they are climbing the walls. They are incredibly anxious. You can imagine what happens. This can really scare people, but absolutely, the vast majority of the time, people say, "The hell with this! I thought this was going to help me, and now I'm feeling a lot worse." And so, as I mentioned before, 2 consequences. They stop taking the medication right now, they just dump it down the toilet. But the other thing, which is really important to, again, re-emphasize, is they may say, "Forget it, I'm never going that way again. I've tried psychiatric drugs, they make you sick." And so here's a person that then opts out of treatment, that otherwise might really be beneficial or even life-saving. So this is a bad news side effect. Now, how often does this occur? The data is not clear, but it's probably somewhere between 10 and 20%. It's apparently occurs somewhat more often, maybe the 20% figure in kids and young teenagers, and maybe a little bit less with adults. But it's such a huge problem that we need to kind of anticipate that until we really know what's going on, we have to anticipate that it's going to happen or potentially can happen. Okay? The anxiety presents just with normal signs and symptoms of anxiety, restlessness, nervousness, trembling, and so forth. But also, if it lasts into the evening, which it oftentimes does, it causes initial insomnia. So people can't go to sleep that night. Now, it's very important to make a distinction between activation, this acute onset side effect, and switching. And it says here on the slide, switching is where a person has been misdiagnosed as having unipolar depression. The prescriber doesn't know, but the truth is they have bipolar disorder, start taking an antidepressant. And switching is where the antidepressant causes the person to switch into or flip into a manic or hypomanic episode. Now, there are a couple of things that really sharply discriminate between activation and switching. The first is the time frame. Activation occurring within hours of starting the medicine or increasing the dose. Switching, typically you have to have take antidepressants for 3 weeks or more, 3, 4, 5 weeks, and then you're going to see manic episodes. Okay, so the time frame is very, very different. The other thing is the nature of the symptoms, because when you have switching, it's not just agitation, it's mania. And so you get flight of ideas, pressured speech, you may have euphoria, you can have decreased need for sleep, and so forth. And what's a real mistake is, if somebody has activation, and then all of a sudden the doctor says, oh my God, this person has bipolar disorder, and they put them on lithium or something. Well, most of the time, that's not the case. I mean, they may have bipolar disorder, but activation, whether you have activation or not, has nothing to do with whether the person has unipolar or bipolar disorder. It's just an acute onset side effect with antidepressants. And if you then start lithium, all of a sudden you graduated into drugs that have huge amount of side effects and also sometimes dangerous side effects. So it's going to be important to keep that in mind. Now, getting back to the whole issue about using SSRIs, a strategy that is a very high-yield strategy is to combine SSRIs with a tranquilizer. Now, I want to be really clear about this. First off, is one group of people you don't want to do this with, and these are people who have a history of substance abuse, including alcoholism. One of the worst tragedies is somebody who's in recovery from substance abuse, and they get put on a tranquilizer, and within a week they are addicted again. Obviously, I think everybody knows that the tranquilizers, the benzodiazepines, that's the class name for tranquilizers, can be addicting to people who have a vulnerability to substance abuse. So this hinges on being able to rule out substance abuse as a problem. But assuming that that's not the case, then the person is sent home with both an antidepressant and a tranquilizer. Now here's the other point I want to make, and that is they go home and they take both of the medications, their first dose together. Let's say it's Paxil and maybe Ativan as a tranquilizer. Within an hour, or a little bit less, the tranquilizer is going to start working. Now, first off, should that person experience activation, if that were to happen, the tranquilizer would be on board and would negate that. So that's good news in itself. But secondly, and maybe even more importantly, is that within an hour or less, this person, again, who may have been experiencing extraordinary anxiety for the last 9 months, starts to really settle down. I mean, these tranquilizers are very potent in their effect on reducing anxiety. And so not only does it negate possible activation, but guess what it does? It gives them immediate relief. And that's what we talked about before. That's what translates into hope. And the person's more likely to say, thank God I went to see this doctor. I feel better already. And the strategy here is to use the tranquilizer for 3 or 4 weeks. Now, it turns out that SSRIs although they often are good for depression, they're very good for treating anxiety disorders. All these drugs were initially FDA approved for treating depression, but in many respects they may even be better at treating anxiety disorders. And by week 3 or 4, most of the time the SSRI has started to have its own very potent anti-anxiety effects, and therefore you can stop the tranquilizer. Some people are concerned about being on tranquilizers for a prolonged period of time. I'll address that issue here in just a couple of minutes, but here you're telling the person up front, we're going to use the tranquilizer for about a month, and then you should be able to stop that so we don't have to worry about dependency and that sort of thing. Now, on the next slide, benzodiazepine augmentation. Again, the benzodiazepines, that's the class name for tranquilizers. It includes drugs like Ativan and Valium and Klonopin and Xanax and so forth. This study by Ward Smith was able to demonstrate significantly fewer dropouts early in treatment if you co-administer benzodiazepine with a tranquilizer. So it's not just something that kind of intuitively makes sense, but there's some research support for this. I also want to show you this next slide, a very interesting study, I think a very important study. And here we're looking at a large group of patients with an HMO, 2,400 subjects, and these people were treated continuously for 2 years or longer on tranquilizers. And this is known because they have pharmacy records and they refilled their prescriptions and so forth. But the important point here, if you look at the bullet item number 3, out of this large sample size, those people that during this 2-year period of time that requested an increase in the dose of the tranquilizer represented a little less than 2%. Now the reason that's important is because when people are periodically asking for higher doses, that's the biggest red flag that they are abusing the drug. With tranquilizers, fairly quickly people develop tolerance for the euphoria that you can get. Some people, I've taken a tranquilizer a couple of times myself prior to some medical procedures. I don't get euphoric, I get sleepy. Okay, but some people get a buzz off of tranquilizers, and these are people that are prone to substance abuse. And so, within a few weeks, the 10 milligrams of Valium isn't giving them the feel-good sensation they had, so they request higher doses. However, and this is something that I think a lot of times is misunderstood, even by physicians, is that the anti-anxiety properties associated with tranquilizers, people typically don't develop a tolerance for. So they can continue to take a certain dose over a period of months or even years and continue to have it be beneficial. So I think what really this research shows is the incredibly low rate of abuse of tranquilizers, at least here in a general medical population. And later we'll talk a lot about controversies and concerns about tranquilizer abuse. That it's a relevant issue to address, but for right now, sort of cutting to the chase, the risks are quite low when you screen for a history of prior substance abuse.